in my heart, I just hope that one day I don't have to give this talk anymore. Because in some ways, it's exhausting and saddening, and sometimes it's hard for me to even prepare it or revise my talk because I'm hoping that one day things will be so drastically different that I won't have to give it. But I remember very distinctly being in college and thinking about what I wanted to do, and I really struggled with what my life path was. And I came across a lot of really interesting literature about health disparities and realized that maybe my life's work was around addressing health disparities and thinking about how we eradicate them, eliminate them, so we never have to discuss them before. And what was really striking to me is for a very long time, we really didn't talk about women's health disparities. We talked about disparities in a lot of other places, but not about women. And so as someone who feels fiercely that the care of women likely determines the status of a society, I felt like we have to. And so disparities in maternal health, I hope will not exist one day, but I do have to say it is the driving force for a lot of my work, sometimes on a very daily basis. I have nothing to disclose financially, I have no financial investments, but I also just wanted to preface that these are my parents, and I had the fortune of spending the weekend with them. My dad actually lives in the South, and my mom lives here in the Bay Area. And I was reminded of how much disparity was part of also my personal reality. Oftentimes we talk about disparities in terms of large population groups because that's how you demonstrate differences and trends, by looking at large groups of individuals and tracking differences between individuals, and we'll go through those definitions momentarily. But that my family reflects a lot of the disparities that we will talk about today. And so even though it's something that very drives me professionally, it's also my reality very much on a daily basis. My dad, on the left, is a Black man. He was born in the segregated South to a single mother who raised 6 children by herself in a single-room home in conditions of significant poverty. And my mother has almost the exact opposite experience. She's a white woman who grew up in urban Los Angeles in a very affluent community. And although they're no longer together, but they had my brother and I feel very fortunate to have them both. Their backgrounds have very much affected their life's trajectory, their well-being, their wealth, their health, in very personal ways. And so I see that on a daily basis or experience it. And so even though I say I have no financial disclosures, I do have to say that I think the topic of disparities is one that personally affects me and touches me, and I can see the realities just at the dinner table on a Saturday night at times. So I just wanted to preface that, because sometimes I feel like I get very emotional or frustrated, or I have to take pauses, and it may be because it's not such an abstract concept to me. I feel like it's very real. So my hopes tonight, and again, are that we accomplish the following objectives, which is to make sure that you guys have all the vocabulary you need to when you discuss issues of disparity and difference, being able to distinguish between health disparity and healthcare disparity, being able to discuss the scope of racial health disparities in our country, give 2 examples of disparities within women's health, because oftentimes we don't do that so well in our disparity discussion until quite recently. And then look at factors contributing to maternal mortality. So, recently we've seen a lot more publicity and discussion in the national media, both in the formal media and social media, about disparities in maternal mortality, which is amazing, and I'm really grateful that the dialogue has started. But these issues are not new. And I'm take a step back to understand sort of why we didn't discuss this, because many of the things that we see today didn't just start 18 months ago, 24 months ago. I mean, when I started medical school, we never talked about differences in maternal mortality. I remember I gave a presentation in residency about maternal mortality because I felt like we just had never discussed it ever, which is fascinating. And I trained at UCSF, which I think is a very progressive, often inclusive, academic, medical environment in comparison to many other academic environments. We weren't talking about it, and I think that silence was deafening. So the fact that I can now open sort of my feed on my phone, and there's an article a day about disparities in maternal mortality, I'm grateful for that, because there's a dialogue now that didn't exist years ago. Many years ago was something else that came out that kind of shocked sort of the medical system, and this is the Institute of Medicine's report called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And this was this huge report. It was over 500 pages long. It was one of the most well-cited reports published about racial and ethnic disparities in care. And the findings were very simple, that racial and ethnic minorities experience a lower quality of care, and in many cases have less access to routine medical services like pap smears and mammograms and colon cancer screening. At any time you critique the medical system, there's this huge response, like, I'm not sure we can believe this, I'm not sure those studies were well done, let's pick out the individual studies and critique the methodology. But I think this report was so powerful and really, I think, shocked people in the medical system, just because it didn't matter how good the study was, whether it was poorly done or one of the most methodologically rigorous studies. It all was reporting very similar findings. That racial and ethnic minorities in this country received substandard of care. And because there was such preponderance of evidence, and I think they were very intentional in the amount of evidence that they published, because it's hard to argue with 500 pages of information that is well cited over and over again. And it wasn't just in one field of medicine, it was in almost every field of medicine. And that's what in part made this report so powerful. Before we go further, I think it's just important to define some of the terms we use, because sometimes they get used sort of incorrectly. And I think to be powerful advocates, it's helpful to make sure that the terminology we use is accurate. And so, there's no one single definition for health disparities that is accepted at a national level. I like the definition by the Centers for Disease Control because it has a few key words I like. Number one, actually, can someone read the definition out loud?
Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by social disadvantaged populations.
Thank you. Mm-hmm. So I like the idea of preventable, that this is something that we can do, that we don't just have to assume that this is the natural way of the world, that this is problematic. I also like the idea of burden. I think it doesn't just say there are differences in disease rates, in the incidence of injury, but who bears the brunt of this unequal distribution of illness, disease, violence, and that we are really striving for optimal health. It's not just so that things are equal, because even for those more advantaged in our society, we still don't necessarily have great health, but we are striving for something more, and I really like that. Now, most of the discussion around health disparities is framed within the context of racial and ethnic disparities. I think think there are growing dialogues here and abroad about disparities by socioeconomic status, education, ability, size, sexual orientation, gender identity. But most of the data, to be honest, is really focused on racial and ethnic minorities, and really often compares blacks to whites. There are some good data sets that collect data about other types of populations, but in general, the analyses have often been limited to blacks and whites. And we're going to talk a little bit about this later on, but part of it has to do with data collection. You don't really ask people what their racial identity is when they enter a medical facility. And so collecting data about people's self-identified race is lacking in most healthcare systems. And there can be a lot of nuances as to why. Now, health disparities is to be contrasted with healthcare disparities. Would someone else be willing to read this definition?
Racial or ethnic differences in the quality of healthcare that are not due to access-related factors or clinical needs, preferences, or appropriateness of the intervention.
This one is very clear in terms of what they mean. And this was the definition used in that unequal treatment report by the Institute of Medicine. They're like, there's a difference in the healthcare received by certain groups. These groups have already accessed healthcare, so it doesn't mean they haven't gotten into the system. So these are individuals within the system who are not getting the same care. Not because they're sicker, or their preferences, or their certain clinical parameters. This is implicitly unequal care. If we look at some examples, one example is that black women are more likely to die from ovarian cancer than white women. It's an example of a health disparity. It means that black women have this unequal burden. When they get diagnosed with ovarian cancer, they are more likely to die from it than white women. If you look at a healthcare disparity, if you look at black and white women who enter treatment, black women are less likely to receive guideline recommended care for advanced epithelial ovarian cancer in comparison to white women. So this is once they've already gotten to the system, they've been diagnosed. They're sitting in front of a provider who makes a decision about their treatment. Black women are less likely to receive guidelines that follows the standard of care. This is a sort of nice guideline that's produced by the double AMC, and I like how it distinguishes between differences and disparities. And it characterizes differences as things that make sense from healthcare or medical perspective. It may be like whether somebody's clinically appropriate or not. Like the decision whether someone gets a kidney transplant should be determined about whether they need a kidney transplant and how sick they are, not where they live or the color of their skin and so forth. And so that would be a difference. Whereas there are racial disparities that exist in the care an individual provider gives a cohort of patients and the care that is given between different providers to patients. And some of those differences include sort of how providers communicate with their patients, but also where does someone access their care? Do they have access to the highest standard treatment? Do they have access to the best imaging? There are great studies, unfortunately, that explore the disparity in breast cancer mortality. Probably the most well-published and documented disparity is in the city of Chicago, where that work has been very meticulously documented. And in large parts of Chicago, predominantly the areas in which you have higher proportions of black women, they don't have access to digital mammography, which is much better in detecting breast cancer than your standard plain film mammography. And so thinking about where people get their care, who they get their care from, is important in thinking about the quality of their And we know that clinical bias is a part of healthcare disparities. We have lots of evidence of this. And that patient identity can influence how their provider asks them questions in an interview, what sort of studies they're going to order for diagnosis, how they manage their symptoms, what they're going to recommend for treatment, referral to specialty care, and how much a provider trusts that someone will come back, that they'll adhere to their medications, and so forth. One of the most powerful studies on clinical bias was actually done in an artificially created scenario. It was published in the New England Journal of Medicine probably about 20 years ago, and it was done at a cardiology conference. And they had 4 individuals who represented patients. They all said the exact same thing. One patient was a white male, one patient was a white female, one was a black female, and one was a black male. They all said the exact same thing on television monitors. And at the conference, this is a cardiology conference, people were assigned to go see one of each video. They couldn't see all of them because they would realize that they all said the same thing. But they were randomly assigned to watch one of the videos. And then they were asked, who would you refer for further testing to assess their heart? And what they showed was that males were much more likely to be referred for additional testing than women, and that whites were much more likely to be referred for testing than blacks, even though they all said the exact same thing. And black women were the least likely to be referred for testing of all of them. And I think this is interesting because when we talk about causes of maternal death in this country, I want you to remember that people are not conceiving black women at risk for cardiovascular disease. And there are a few examples of clinical bias within women's health in comparison to other specialties. Most of the work is in cardiovascular health and renal transplant. But I think some of these examples are interesting and reflective of things that then get perpetuated in systems of how we care for women. So black women are less likely to receive information and prescriptions for hormone replacement therapy, which happens in the menopausal period. In a similar study to that one that I just described about cardiology, someone tried to replicate it in terms of asking about physicians' willingness to sterilize women or perform tubal ligation postpartum, and physicians were more willing to do that for black women and for women than women who were more fluid or white. Again, all theoretical, not based on actual experience. And then during pregnancy, low-income black and Latino women are more likely to report being encouraged to limit their family size than middle-class whites. And we talked about the example of guideline recommended care for advanced epithelial ovarian cancer. And there are many different models of social determinants of health. I can't say that I found my favorite one yet, but I think it does. What I like about this diagram is it shows that there are many things that affect the distribution of health and well-being. Oops, I'm so sorry. This happens. But the Institute of Medicine really focused on the healthcare system, which I think was really important because a lot of times I think when we talk about health disparities, at least in the medical profession, it's talked about a problem that is so huge that no one can take any responsibility for it. And so I think that report was really timely and necessary because it turned the lights on the medical profession and it said, you play a very big role in perpetuating the disparities that we see in this country. And although you may come to medicine with hopefully the goals of treating everyone equally and providing optimal care, the evidence is to the contrary. And it's fascinating because When you do studies of physicians and you ask them about disparities and bias, very high rates say that there are disparities and bias in our healthcare system. And then when you ask about their own role in perpetuating those disparities and bias, very few acknowledge participating. So that was the power of this report. And this came out, now like 20 years before we're talking about maternal mortality. But I think it was really important. But then I also think it's really important to take a step back, because even though healthcare disparities are a part of disparities in our country, they're part of it. They're not all of it. The health disparities that we see today exist in this broader context of contemporary and historical inequality. And I think just focusing on the healthcare system can be too narrow. It can be too close-minded. It also limits the number of individuals who can be involved in this movement to hopefully eradicate these disparities. And if you think about all those things that contribute to health, disparities in income, education, incarceration, wealth, housing, safety, parks, healthy food, those then play a role in people's well-being. And so to only focus on healthcare disparities is too narrow. If we think about how racial disparities affect our country, I think many people will argue that given the persistence of such pervasive disparities across all fields of health, we will never achieve great health in this country. But some people don't like that sort of lofty goal. It's too broad, it's too ethereal for them. Too out of reach. And so some people need numbers, and there was this great study done by David Satcher, who was the U.S. Surgeon General. And all he did was look at the difference in death rates between whites and blacks. That's it. It was very simple. He said, in this year, in 2005, how many more blacks died because they died prematurely than whites? And he estimated that over 80,000 blacks in the year of 2005 died, just given this discrepancy in mortality rate. He didn't talk about how are people living, what is their quality of life, things like that, just the difference. And he said over 80,000 lives were lost just because of this disparity in death rates. If we look at the leading causes of death in 2005, if disparities could have been a cause of death, it would have been the 6th leading cause of death, which is pretty fascinating. And in his article, he mentions, which is also shocking to me, that this would be equivalent to a jumbo jet carrying over 200 black passengers crashing every single day for a year, which is tremendous. If we ever had that happen, and where we saw a jet crash every single day, there would be a national emergency. We would rally all our resources. We would figure out why those jets kept falling from the sky. But for some reason, we haven't yet been sort of called to action. Today, that number is likely to exceed 100,000 and probably fall similarly on the leading causes of death. So if you look at some estimates, the number of deaths from breast cancer and prostate cancer would be equal to the number of deaths from racial disparities. So one of the big goals in the conversation on racial disparities is really trying to understand why. Why do these disparities exist? Which I always think is fascinating, because we see inequality in so many other parts of our lived experience here, but when it comes to health, people are like, I don't understand why they exist, which I think is naive. And racial disparities are attributed to these three common explanations. One, there are biological differences. Two, they're just really accounting for differences in socioeconomic status. And three, differences in health are really driven by differences in patient preferences. And I wanted to spend a few minutes on these because I don't believe them really at all. And I want you also to have the language to counter them. So if we start with biological differences, I think erroneously, especially in the medical literature, race is assumed to be a biological category. And it's still, even to this day, I sit through many talks and people discuss race as it's an innate, inherent characteristic written in people's DNA, which then predicts the rest of their lives. But we know that is absolutely false. I think one of the greatest things about the Human Genome Project was that it showed that there was no scientific basis for race. But still, we continue to act as if that race is some inherited condition that gets passed on from one group to the other. And the problem with that is many. There are many problems with that. But it then, when we look for solutions for racial disparities, remedies for these horrible inequities that plague our society, we're looking in the wrong places. It distracts us because we try and look for biological solutions when in fact we're not dealing with a biological process. We're dealing with a social one. And we know there's a vast amount of information about the impact that race, and really we should use racism, has on people's health, particularly women's health. And I know, and I think that your website, which I think is gorgeous, that you have an upcoming talk about the impact of racism on women and maternal health. So I'm not going to spend a lot of time on that, but there's this great systematic review that said, let's look at all the data and all the studies that look really at the idea of racism and how it impacts health. And what you see is that you have racial discrimination, but then on the other side, you definitely see cardiovascular disease, decreased birth weights. I didn't write preterm birth, but up there. And how these experiences associated with stress, along with an inability to fully participate in all the measures that can promote health and well-being, can lead to differential outcomes of health. And so, describing racial differences in health outcomes as being caused by biological processes is very dangerous, because it really ignores the underlying causes of many of these disparities. And then if we look at differences in socioeconomic status, well, we know that there are links between poverty and lower educational attainment and lower health outcomes, or worse health outcomes. But often, very easily, people are like, well, race and socioeconomic status overlap so much in this country that all the racial differences that exist, you can just explain away when you adjust for socioeconomic status. But what was fascinating in that Institute of Medicine report, which is I think one part of its power, is they said, sure, the disparity may attenuate and may get smaller. And in some cases it does completely disappear when you control for socioeconomic status. But in the vast majority of studies, that racial and ethnic difference, that disparity, persisted even after you adjusted for socioeconomic status. This is one of those graphs that is, I think, utilized very frequently when talking about health disparities, because I think it's really powerful. And so, women in this study, when they looked at infant mortality rates, were divided into groups by education, or stratified by education. So you had women who had less than a high school education, women who completed high school, and women who had some college education and beyond. And then within each sort of category of education, you had infant mortality rates reported by race. And what you'll see is for each of the educational strata, non-Hispanic Black women have the highest rate of infant mortality, followed by American Indian and Native Alaskan women. I want to draw your attention to this category. So this is the category of college-educated women. If you look at the infant mortality rate for a Black woman, it's 11.5 per 1,000 live births. If we go back up to women who have less than a high school education, you see that this number exceeds the number for every other racial or ethnic group. I think this is a really powerful slide because oftentimes I think we try and explain some of the gaps, the differences, the disparities that we see between Black women and other populations solely based on education, solely based on income. But you can see even among the most educated Black women, they still have an infant mortality rate that exceeds all other groups of women, which I think is really powerful evidence that we cannot just attribute racial and ethnic disparities to differences in socioeconomic status. And then the last sort of reason people often give for explaining disparities in care is patient preferences. It says, if you look at sort of which patients decline recommendations by their providers, it is more common amongst individuals of color, and these reasons are complex. It can be for distrust of a medical system that never sort of advocated for them. It can be barriers to communication between a patient, their family, and their provider. But what I think this report, this Institute of Medicine report, also did a very nice job. It said, yes, minority patients are more likely to decline care, but the number who did so was so small and did not affect the disparity in care. So that disparity persisted despite different patient preferences. And so one of the things I like, and I think I'm going to start using it more frequently, is we often use the term health disparity. But I think sometimes that term, because now we use it so frequently, doesn't shock people the way it used to. And the CDC proposed using the term health inequity. And I love it because it attaches a judgment to something I think that should be judged. And it says, oh, someone could read this for me. Who wants to read it?
Health inequity, a difference or disparity in health outcomes that is systematic, avoidable, and unjust.
Like it assigns judgment to something that should be judged. It's not just a statistic anymore. It is something we should be morally outraged about. We should have righteous indignation. We should be outraged. And I like this. And so maybe going forward, you'll use this term more frequently when we describe differences in health outcomes, because I think it implies that it's not acceptable. It's not just an interesting statistical finding. It is unjust, it is wrong, and it is systematic. And these are examples of disparities within women's health. I like participation. Maybe people can take turns reading different ones.
Rate of preterm birth in Black and Puerto Rican women is substantially higher than that for white women.
Black women experience the highest infant mortality rate.
Black women are nearly twice as likely to die of cervical cancer and uterine cancer as white women.
Black women have a higher death rate from breast cancer than white women, despite a lower incidence rate.
Black women have the highest rate of unintended pregnancy of any racial or ethnic groups.
How do you feel when you
two clients who are Black moms and they lost their babies. It's infuriating and sad.
Sometimes this, I think, can get very intensive, overwhelming, and sometimes I even have to take a pause, and I created this slide, and I've said this many, many times, and I discussed it many, many times with patients, my colleagues, my friends, my family members, but I still find it somewhat overbearing. And I think being moved means that it still affects us, which I think is really important, because when we become numb to it, then I think we're really in danger. So when I thought, so I've had this, and I apologize, but I didn't intentionally. I wanted to make sure that we thought very carefully about the definitions of disparity, how we talk about disparity, at least in the health and medical literature. And I know that I was given the assignment of disparities of maternal health, and I thought, wow, this is a big topic. And I felt honored to speak, but also overwhelmed by how big it was. So I decided to be very narrow in my focus, intentionally, but also because as I was preparing my presentation, I started working on disparities in preterm birth, and I kept thinking in my mind, okay, here I go again. I'm going to tell a similar story. The outcome is very similar. And I had to stop because I too sometimes am overwhelmed by this. And so, we're going to talk about maternal mortality and severe maternal morbidity, which is not a light topic. But I think it illustrates some of the things we see in many other areas of maternal and women's health. This infographic, I think, is really powerful for a lot of reasons. I like things that summarize things quickly, which may be why we move quickly often in terms of making decisions or thinking about things. But this diagram is very clear. This is global maternal death. And from 1990 to 2013, we see a nice decline. Annually, maternal mortality has fallen globally by almost 3%. Many countries, you can see over 100, have experienced accelerated decline in maternal mortality, which is awesome. I mean, for years people thought this was never going to budge. It's just the reality of the world. 7 developing countries are on track to meet their goal of reducing maternal mortality by 3/4. That's awesome. However, 8 countries have had an increased rate in maternal mortality. Ours, the United States, being one of them. And I think it's important to talk about maternal mortality overall. Because when you talk about maternal mortality is probably one of the #1 public health indicators in the US, globally. And we're doing bad. This is a diagram. I told you I like diagrams, I like visuals, and I think it's also very striking. So this really features mostly developed Western nations, and it trends their maternal mortality from 1990 to 2015. So almost that same graph that I just showed you. And what's very clear about the blue line, they're going down. Yet ours is going up. A lot of times people ask, well, is this really a true increase? Or is it just now that we're talking about it more, we're collecting more data? And so it's actually because we collect more data about it, we're actually more accurate in our estimates. And so maybe this is all just a function of better data collection than a difference in reality. Well, it's interesting because Canada uses a similar data collection system to ours, but their declines are going down, and yet ours are going up. And if you look at the number, so this is the number of maternal deaths per 100,000 live births, and in Canada that number is 7, and in the US that number is 26, so almost 4 times as high. So there is a problem, and it's not just around data collection, despite what we'd like to say. And this is the data, and I have to be honest, always these statistics lag by several years. So even though we're now in 2018, it's probably that we're just starting to see data from 2014 and 2015, because they're always behind. And what you see is if the United States is in red, and you can see California's in blue. And again, you see that steady increase. And we should be shocked, because if you look at what the maternal mortality rate in the United States in 1999, it was almost 10. And now, from our most recent data, it's double that. We'll talk about California in just a moment. But I think that that's pretty shocking. So a lot of people are like, well, why? Like, why are we seeing this huge increase in maternal mortality? I thought our healthcare was getting better, more advanced, have better ways of detecting things, monitoring things, so forth. Well, some people are not totally sure why it has gone up so much. Things that people have speculated is that we have a number of older women who are now giving birth, and a significant contribution of deaths occur amongst women aged 40 and older. And that's across all racial and ethnic groups. Age is a significant predictor of maternal death. You see it, if you look at age 35, it then increases to 40, and then for women who are 45. But also people who are more ill, who become pregnant, and then how does their comorbidities affect their pregnancy, and how does their pregnancy affect their comorbidities? We're seeing higher number of C-sections. We're seeing a healthcare system that is extremely fragmented. The people someone may see for their female care may not be those that work in the hospital and take care of them. And I love the fact that you're focusing on the postpartum period, because postpartum care is horrendous. It doesn't really meet the needs of women. In many places, women lose their insurance, especially if they have public insurance, after 6 weeks. Which, if anyone's had a child or knows someone who has a child, knows that 6 weeks is the shortest period of time possible. And that many things that manifest themselves in pregnancy predict sort of long-term risk as well. And if you lose your access to health care when someone has just revealed sort of risk that you may have in your future, we are not supporting them, and we're not setting them up. And we're also, I'm glad you're talking about we don't support women in terms of taking care of themselves and their families. And so the reasons for this increased maternal mortality are complex and interrelated. And then, just so that we're clear about definitions, because I told you I'd make sure that you guys knew all your definitions. A maternal death, and this is what is used internationally, is defined as a death of a woman while pregnant or within 42 days of the end of pregnancy that is from any cause related to or aggravated by pregnancy or its management. So a woman who dies from a ruptured ectopic pregnancy has a maternal death. Someone who dies after hemorrhage from a term delivery, that's a maternal death. What is not counted is someone who has an accident or an injury that is not related to their pregnancy. So if they were driving down the road at 3 weeks postpartum and someone hit their car and a woman died, that's not counted as a maternal death. Then there's pregnancy-associated death. That's a death of any woman from any cause while pregnant within a calendar year of her being pregnant. And this is just to collect all possible deaths, and this may be part of the strategy in terms of understanding more about data collection and making sure that each woman who dies around the time of pregnancy or near the time of pregnancy is counted. And that's to be distinguished from a pregnancy-related death. And this intentionally is supposed to suggest causality. There's something about the pregnancy that led to her death. There's a chain of events, either from the pregnancy itself that caused her death, or she had an unrelated condition which was worsened, aggravated, and led to her death because of her pregnancy. An example of somebody who had heart failure before they got pregnant, and then during their pregnancy, their heart decompensated, and they died during that, that would be a pregnancy-related death. And that's within a year. And so if we go back to this slide, these are rates based on maternal mortality, meaning a death of a woman within 6 weeks of the end of her pregnancy or during her pregnancy. This is not for an entire year. What I think we should be excited about, because California is one of the few states, is that in our state, we've actually seen a decline in maternal mortality. We have now met, and actually we met the goal several years ago, around 2009-10, for the Healthy People 2020 goal, which was to have a maternal mortality rate less than 11.4. It's interesting, California was one of the first states that started with review committees that looked at every death, likely pregnancy-associated death, to determine if they were true maternal deaths, pregnancy-related deaths, and to understand what was the cause of death, and if that cause of death was preventable. In addition, California has rolled out the California Maternal Quality Collaborative, which has done a huge job at infrastructuring systems of care around how to take care of women, particularly during obstetric emergencies like hemorrhage and preeclampsia, high blood pressure. And these sort of bundles of care have been implemented in many, many hospitals and settings to standardize how we take care of women. And people attribute these two initiatives as having a significant impact in lowering maternal mortality in our state. And I realize I'm running short on time, so I'm going to run through some of these slides a little fast, but if you look at the causes of maternal mortality in this country, you can see that the etiology of hemorrhage and hypertensive disorder of pregnancy are declining causes for maternal mortality. And I think this is in large part due to the efforts around standardizing care. Whereas you see things like cardiovascular conditions, cardiomyopathy, stroke are increasing causes of maternal mortality. And I think this is interesting because we also know about the impact of racism on cardiovascular disease, stroke and high blood pressure, and cardiac function. So I think it's interesting, although that hasn't been part of the discussion, I think it's an interesting observation to think about sort of why are more women of color dying in pregnancy. And then if we look at the disparity in maternal mortality, maternal mortality for Black women far exceeds that for white women. And it's fascinating. You know, I told you the story about the Institute of Medicine published a study in 2000, was reported in 2002 that shocked the world about the evidence of disparities in healthcare. What's really frightening to me is that this disparity has existed really since the time we have kept vital statistics. So since the 1930s and 40s. And it's been persistent. I mean, non-Hispanic Black women are 3 to 4 more times likely to die for pregnancy-related causes than non-Hispanic women. It hasn't changed. And in some ways, it's gotten worse. I found this one interesting statistic that helped frame this. It said that Black women are 22% more likely to die from heart disease than white women, 71% more likely to die from cervical cancer, and 243% more likely to die from pregnancy or childbirth-related causes. And what's shocking to me is this has been persistent for decades. And I am very appreciative that the conversation has highlighted this disparity in the last 18 to 24 months. But for decades, we were silent about this. And American Indian and Native Alaskan women are estimated to also have a significant disparity. And they are 2 times more likely than white women to die from such causes. And I just showed you that graph, which everybody loves, about California, which shows the U.S. mortality going up and California's maternal mortality going down. If we look at the disparity between white women and Black women, reassuringly, Black women are in the blue. This is the ratio. The red is the ratio between Black women and white women. White women are in the green. So reassuringly, the maternal mortality for Black women is not as high as it was when it peaked. We're talking 51 women for 100,000 lives births. I just showed you the data for Canada. It's 7 times what it is in Canada. It's come down. But what has not really changed, despite our improvement, is that persistence of that disparity. It's still 3 to 4 times. Meaning, although overall we're having fewer maternal deaths, the degree of difference is still the same as it was in the 1940s, the 1990s, the 2000s. And the numbers don't matter so much, but if you look at, the numbers matter a lot, but in terms of understanding this slide. But if you look at the colors, so the darker colors correspond with higher maternal mortality rates by states. And there was this very interesting study published in a prominent obstetrics and gynecology journal. And what it found is that the state's ranking for maternal mortality was associated with the percentage of the population that was Black. Meaning that the higher the percentage of Black individuals in that state correlated with lower sort of rankings in terms of maternal mortality or higher overall maternal mortality. And so if you look at this slide, this is maternal mortality overall for the state. And then if you look at, you see the same, this is the maternal mortality rates for Black women, and the colors are the same. So where you have higher maternal mortality rates, you have higher percentages of Black women living in those states. And I think this is important because they very clearly showed that the racial disparity was in large part driving many states' maternal mortality. the attention that maternal mortality gets, there are only, and I say only, and I'm very mindful of that word, there are only about 700 maternal deaths in the US per year, which is contrasted to other countries which have many. Although that number is still shockingly high, we just discussed why. Maternal deaths only actually represent the tip of the iceberg. What we're missing when we talk just about maternal mortality is severe maternal morbidity. And for every maternal death, 100 women will experience severe maternal morbidity. And I'm going to define that in a moment. And what's interesting is if you look at data from late 1990s to the late 2000s, there was an increase of about 75% in the incidence of severe maternal morbidity. And if we define maternal morbidity, it's the unintended outcomes of the process of labor and delivery that result in significant short-term or long-term consequences to a woman's health. And I spared you the long list of everything that counts under this, but gave you some examples like hemorrhage requiring 4 or more units of blood, eclamptic seizure, septic shock, which means that you have low blood pressure and you need fluid or you need something to constrict your vessels so you perfuse your vital organs, use of a ventilator, peripartum cardiomyopathy, which is a form of heart failure, admission to the ICU, stroke. I could go on and on. And so when we think about maternal mortality, we're outraged and we should be very concerned about our rates of maternal mortality. But we should also be very worried about severe maternal morbidity, which is often not discussed. Because the events that take place at birth or thereafter can affect a woman's ability to care for her family and her own personal well-being for the long term. And the disparities that we see in maternal mortality are the same that we're seeing in severe maternal mortality. So Black women have the highest rate of severe maternal mortality, but so do Alaskan Native, American Indians, Hispanics, Asian Americans. And often we don't discuss this, but severe maternal morbidity affects over 60,000 women per year. And that's in contrast to maternal deaths of probably now estimate around 700 per year. So why? Remember I told you when we were talking about disparities, we're always so fixated on why. Why do they exist? Well, this is another one, and I like this model of how the social determinants affect the outcomes we were just talking about, severe maternal morbidity and mortality. It looks at patient factors, community neighborhoods, provider factors, citizen factors. It says all these things affect someone's health status. And then that health status then enters the system, either when they get preconception care, antenatal care, delivery, or postpartum care. And those things then affect outcomes in terms of severe maternal morbidity and mortality. And we have data that there are many things in that model that then lead to differential access, differential care, differential experiences for women of color. I told you that Black women have the highest rates of severe morbidity, maternal morbidity. Black and Hispanic women also enter pregnancy with more comorbidities than other women. Likely because of all those factors, patient, community, society, structural factors that affect their health, and their bodies bear witness and burden of the inequalities in our lives, and then they bring those into their care, into their pregnancy. Black women have the highest case fatality rate. I'll show you this in a moment. What's also very interesting is racial ethnic women tend to deliver in different and lower quality hospitals than whites. In a national study, they looked at where Black women deliver, and 75% of Black women deliver in about a quarter of all hospitals in the country. So you're concentrating individuals within certain health systems. And when you looked at those hospitals, they disproportionately had higher rates of severe maternal morbidity for both whites and Blacks. So Black women are getting their care in systems of care that are providing often what's assumed lower quality care to all patients that walk in their door. But because Black women are concentrated in these hospitals, they in part are experiencing that unequal care inequitably. And then when you ask women about their experiences at the time of birth, Black and Hispanic race was associated with higher odds of discrimination at the time they were hospitalized during their birth, which is just a small window of all the times that these women interact with the healthcare system. And this, I find this study so profound because it was published over a decade ago, but I just think it really emphasizes the things that we're talking about. This was an epidemiologic study, and it looked at women in North Carolina hospital, and it looked in North Carolina, the state, and their hospitals. And it looked at 5 common pregnancy complications: preeclampsia, eclampsia, placental abruption, previa, hemorrhage. And they looked at who had these conditions during their pregnancy, and then how many women died because of these conditions. They looked at them by race. And I know this is very busy with lots of data, but if you look here at the prevalence, for those who know statistics, Black women are slightly higher, just on raw numbers, to experience these conditions except for postpartum hemorrhage. But you can see the confidence interval crosses 1, so they're not significantly different. But then if you go to the far end of this table, you look at the case fatality ratios, and you can see they are above 2 for everything, meaning that Black women who have these conditions were 2 times more likely to die from them than white women. And this is just in a hospital setting. This is just when they experience these complications in a hospital setting. And all these confidence intervals cross 1, meaning they are all significant statistically. And so we think a lot about what causes disparity. We know that socio-demographic factors play a role. We know that when someone enters prenatal care, how much prenatal care they get can influence pregnancy outcomes. But still, even when you adjust for many, many factors like age and hypertension and how many visits you had and when you delivered your baby, it still doesn't explain the racial disparity. And I put this picture of Shalom Irving. How many people have read that ProPublica article about Shalom Irving? You have? Yeah. It's one of the most powerful things you can read, and I can share that reference with you. But it's about a woman who sadly and ironically worked for the Centers for Disease Control. She was a public health epidemiologist, and she studied disparities in health. And she died postpartum. And her boss, who is often the author of several studies that I've cited today, was in shock when he received a call that she had died. But part of the premise of the article is, it doesn't matter how educated you are, it doesn't matter how connected women are, Black women are dying at unheard of rates in this country. And remember, I told you that the deaths are much fewer than the near misses, the almost deaths, the disability that occurs after a horrible event during pregnancy. And we're having a conversation finally about racism and how it affects women's bodies. I walked in when you guys were talking about, I think your goals for the course, I missed what the exact prompt was, but I loved the interaction, and someone said, sometimes I'm overwhelmed by this information. And my goal tonight is not to overwhelm you, but to give you the, because if we look at maternal deaths, there's some estimation that about 40 to 60% of all maternal deaths are preventable. And she says, let's see if we can focus on those. And she lists sort of what she thinks are the big issues in disparities in maternal health, and particularly maternal mortality. And she says, one, you can't really even assess disparities. You don't even have the data. We don't, as I told you, in many systems, so many places keep sort of quality indexes on how many people get readmitted within 30 days of discharge from the hospital, how many people get an infection while in the hospital. Why don't we get the same for disparities? How many women are delivering preterm who identify as women of color? How many maternal deaths are often hard in hospitals because hopefully they don't have any more, they have none. But could you do that for health systems so that people keep track of these things? With communication barriers, making sure that we're appropriately using interpreters, because in many places people don't use interpreters appropriately. And so it would be amazing that you can deliver quality care if you cannot effectively communicate with your patients and your patients can't effectively communicate. Also, how do you make shared decision making so that women feel invested, involved, respected, empowered in their care? And then when we think about fragmentation of care, one of the biggest things is access to your own records. Has anyone ever tried to get their own medical records themselves? Have you had any luck with it? It's amazing. We protect your own health records from yourself. You know how many forms I have to fill out for someone so I can get their records so I can take care of them. What if we allowed women to care for their records themselves? I've seen many patients from other countries. And what I think is fascinating is they have their own document where they write down their blood pressure and their weight and their fundal height and how they're feeling. And I do the same in my record, but that's their record that they then can take anywhere. It then allows people to communicate about what are their health priorities and their needs. Because if you have barriers to communication and patients are not fully understanding what is going on with their bodies, or they're not able to express to their providers what they need, having a record that they control themselves would allow for more continuous, uninterrupted care. Fragmentation of care also implies all the different ways in which we take care of people. I have to say, there are some people who just do prenatal care. They do not participate in labor and delivery. They do not provide postpartum care. We talked about how finite postpartum care is, but we don't think about it as a long-term trajectory in terms of women's health care. How do we help women navigate all those different systems? How do we help them coordinate an incredibly complex system? I'm a physician. I work in a healthcare system. And I sometimes don't even know how to schedule my own child's pediatrician appointment. What if I really needed something urgently, in a timely fashion? Pregnancy has very clear time parameters. And if you have to figure out how to navigate that in our very complex system, it is hard. And so when women do, I always am like, you're amazing because you did something I couldn't even do myself. It is hard. So think about how we coordinate that. How do we think about that system? I realize my time is up and I'm not. But I hope that you appreciate that racial disparities, unfortunately, are ubiquitous in our healthcare system. Right now, the conversation really is on women's health and maternal mortality, and I am so glad. And I hope we utilize this opportunity really to make a difference, to be reflective about why disparities are so persistent in our setting. This is the time, and I am very privileged and honored to talk. Thank you.